One swollen leg does not automatically mean a blood clot, but a new, unexplained difference between the legs should not be dismissed as normal aging either. If the swelling is accompanied by sudden shortness of breath, chest pain, especially pain that becomes worse when breathing deeply, fainting, severe lightheadedness, a rapid or irregular heartbeat, or coughing up blood, seek emergency medical help immediately. Those symptoms can occur when a clot reaches the lungs, causing a pulmonary embolism. A pulmonary embolism can occur even when the leg symptoms were mild or unnoticed. If there are no chest or breathing symptoms, the first practical distinction is this: swelling that develops suddenly in only one leg, particularly without a clear minor injury, deserves prompt medical assessment. It may turn out to be a vein problem, a skin infection, inflammation around the knee, lymphatic swelling, or an injury. But a deep vein thrombosis, or DVT, usually cannot be confirmed or safely excluded by appearance alone. This information is especially relevant after 60 because blood clot risk rises with age, while previous surgery, hospitalization, limited mobility, cancer, heart or lung disease, a previous clot, and several other conditions can increase that risk further. This video cannot determine why an individual leg is swollen. What it can do is help separate emergency symptoms from urgent symptoms, explain the most common patterns, and prepare you for the questions and tests that may follow. Why swelling on one side changes the investigation. Swelling happens when fluid collects in the tissues. That can occur because pressure inside the veins has increased. A vein has become blocked. Inflammation has made small blood vessels leakier. Lymphatic drainage is impaired, or tissue has been injured. When both legs swell in a similar way, clinicians often consider body-wide causes such as heart, kidney, or liver disease, medication effects, or prolonged inactivity. These conditions can sometimes affect one leg more than the other, but they more commonly produce swelling on both sides. When only one leg is newly swollen, attention shifts toward a problem within that leg or the veins and lymphatic vessels draining it. Important possibilities include DVT, cellulitis, an injury, a ruptured Baker's cyst, superficial vein inflammation, chronic venous disease, lymphedema, and the lasting effects of an earlier blood clot. The speed of onset is one of the most valuable clues. Swelling that appeared over several hours or a few days has a different risk profile from swelling that has slowly increased over months. Sudden swelling raises greater concern for a clot, infection, injury, bleeding into the tissues, or a ruptured cyst. Long-standing swelling is more likely to involve inefficient veins, damaged lymphatic drainage, or the after effects of an older clot. However, more likely is not the same as certain. A long-term condition can suddenly worsen, and a new clot can develop in a leg that was already chronically swollen. That is why the comparison should not simply be between the left leg and the right leg. It should also be between what the leg looks and feels like today and what is normal for that person. The first urgent possibility: deep vein thrombosis. A DVT is a blood clot in a deep vein, most often in the lower leg, thigh, or pelvis. Part of the clot can break away and travel to the lungs, creating a pulmonary embolism. DVT requires prompt medical attention, while possible pulmonary embolism requires immediate emergency attention. Possible DVT symptoms include swelling in the affected leg, unexplained pain or tenderness, warmth, and red or otherwise discolored skin. The entire leg may be enlarged, or the difference may be most noticeable around the calf or ankle. But the classic picture is not always present. A leg does not have to be dramatically red or extremely painful for a clot to exist. Some people with DVT have few symptoms, and the CDC notes that many have no obvious symptoms at all. Lack of pain, therefore, does not reliably rule out a clot. Several details can raise suspicion. These include recent major surgery, a hospital stay, several days spent mostly in bed, a leg cast, a fracture, severe muscle injury, reduced mobility, active cancer or cancer treatment, a previous DVT or pulmonary embolism, a family history of clots, and long periods of sitting. Risk often increases when several factors occur together. Long-distance travel can contribute, especially when it involves sitting for 4 hours or longer and the person has additional risk factors. But travel is only one possible factor. A person does not need to have taken a flight or a long car journey to develop DVT. Another important point is that symptoms cannot diagnose the condition. Calf squeezing, pressing the swollen area, checking whether the foot can be flexed, or comparing pain while walking cannot safely prove or exclude DVT. Evidence-based diagnostic pathways combine medical history, examination, and objective testing. Clinical assessment alone is not reliable enough to establish or exclude the diagnosis. This is why a newly swollen leg should not be massaged aggressively in an attempt to break up fluid. It should also not be treated with leftover blood thinners. Anticoagulant medicines can cause serious bleeding and should be used only through a qualified clinician who has assessed the situation. When one-sided swelling is an emergency. One-sided leg swelling becomes an emergency when it appears with symptoms suggesting that circulation or breathing may be threatened. Call emergency services for sudden breathlessness, chest pain, coughing up blood, fainting, severe lightheadedness, very low blood pressure symptoms, or a fast or irregular heartbeat. Chest discomfort caused by pulmonary embolism may become worse with a deep breath or cough. A severely painful, rapidly enlarging leg also deserves emergency assessment, particularly if the leg becomes pale, blue, unusually cold, numb, or weak. Those features can signal a serious circulation problem, major tissue pressure, significant bleeding, or another condition requiring immediate examination. Do not drive yourself if you are faint, severely short of breath, or experiencing significant chest pain. Use emergency services. Emergency guidance should not be delayed while trying home remedies, waiting to see whether elevation works, or searching for a perfect match between your symptoms and an online description. The other urgent possibility, cellulitis. Cellulitis is an infection involving deeper layers of the skin and underlying tissues. It commonly affects the lower leg and can cause swelling on one side. The affected area is typically painful, hot, swollen, and red, although redness can be harder to see on brown or black skin. The skin may look shiny, feel tender, or develop blisters. Some people also feel feverish, shivery, weak, or generally unwell. Cellulitis usually needs antibiotic treatment and can become serious if it is not treated promptly. The infection may enter through a visible cut, scratch, ulcer, insect bite, or cracked skin between the toes. At other times, no obvious entry point is found. Diabetes, eczema, athlete's foot, reduced immunity, chronic swelling, and breaks in the skin can increase vulnerability. Cellulitis and DVT can resemble one another. Both may produce swelling, warmth, discomfort, and color change. A fever or a spreading patch of tender skin may point more strongly toward infection, while recent immobility or surgery may increase concern for DVT, but these patterns overlap. A person should not decide that a red swollen leg is only cellulitis or definitely a clot based on color alone. Occasionally, more than one problem can be present. A hot, painful, swollen area should receive urgent medical advice, particularly when the redness is spreading, the person feels unwell, or there is diabetes, immune suppression, poor circulation, or chronic lymphedema. Chronic venous disease, a common but usually slower pattern. One of the more common explanations for gradually developing leg or ankle swelling is chronic venous disease. Healthy leg veins contain valves that help blood travel upward toward the heart. When these valves do not work effectively, blood pools in the lower leg. Pressure rises inside the veins, and fluid moves into the surrounding tissues. Symptoms may include aching, heaviness, itching, ankle swelling, visible varicose veins, and skin discoloration. The swelling is often worse after prolonged sitting or standing, and may improve after resting with the leg elevated. Changes usually develop slowly rather than appearing dramatically within a few hours. Although chronic venous disease commonly affects both legs, one leg can be worse. Previous DVT can damage vein valves and leave persistent swelling known as post-thrombotic syndrome. A history of an earlier clot is therefore relevant even if that clot occurred years ago. Skin around the lower leg may gradually become darker, dry, itchy, thickened, or inflamed. In more advanced disease, a wound may develop near the ankle and heal poorly. Those patterns are different from a sudden unexplained change. If someone with known varicose veins develops new rapid swelling, unusual calf pain, or sudden warmth, the existing vein problem should not automatically be blamed. Varicose veins do not protect against DVT, and a clot can occur in a person who already has chronic swelling. Treatments for chronic venous disease can include physical activity, leg elevation, weight management, skin care, and professionally fitted compression. However, compression is not automatically appropriate for everyone. People with possible arterial disease, a new suspected clot, severe infection, or certain other conditions need clinical assessment before beginning strong compression. Lymphedema. When the drainage system is impaired. The lymphatic system collects excess fluid from tissues and returns it to the circulation. When lymphatic vessels or lymph nodes are damaged or obstructed, fluid can accumulate, producing lymphedema. Lymphedema can affect one leg or both. Early swelling may be soft, leave a temporary indentation when pressed, worsen during the day, and improve overnight. Over time, it can become persistent. The tissues may feel firmer, the skin may thicken, the limb may feel heavy, and movement can become more difficult. A history of lymph node surgery, radiation treatment, cancer, repeated infection, significant injury, or long-standing reduced mobility may provide an important clue. Swelling can involve the foot and toes as well as the ankle and leg. Lymphedema often develops gradually, but a sudden change still matters. People with lymphedema have an increased risk of cellulitis. If an already swollen leg becomes newly hot, painful, red, or much larger, especially with fever or chills, urgent assessment for infection is important. Management often requires more than simply taking a water tablet. Depending on the cause and the person's overall circulation, treatment may involve specialist compression, exercise, skin care, and lymphatic therapy. Diuretics remove fluid through the kidneys, but they do not repair damaged lymphatic drainage and are not appropriate for every type of swelling. Prescription treatment should never be started, stopped, or increased solely because one leg looks larger. The knee problem. That can imitate a clot. A Baker's cyst is a fluid-filled swelling behind the knee, often associated with arthritis, inflammation, or another knee problem. It may cause fullness behind the knee, stiffness, knee pain, and swelling in the lower leg. If the cyst becomes large or ruptures, fluid can track into the calf, producing sudden pain and swelling that may resemble DVT. A clue may be a recent increase in knee discomfort or a feeling of tightness behind the knee. But that does not safely settle the diagnosis. A ruptured cyst and DVT can look similar, and increasing calf pain or swelling should receive medical evaluation to rule out a clot. This is a useful example of why symptom matching has limits. A benign explanation may be possible, but the more dangerous explanation must sometimes be excluded first. Injury, bleeding, and joint inflammation. Not every swollen leg is caused by a vein or lymphatic disorder. A muscle strain, tendon injury, ankle sprain, fracture, insect bite, or inflamed joint can cause local swelling. There is often a clear event, such as a fall, twist, impact, or sudden pain during activity. Bruising, pain during a particular movement, and swelling centered around one joint can support an injury-related explanation. However, older adults may sustain fractures or significant soft tissue injuries after what seemed like a minor incident. People taking anticoagulant medication can also develop larger bruises or internal bleeding after relatively small injuries. A rapidly expanding bruise, severe pain, weakness, numbness, or inability to bear weight requires prompt assessment. Anyone using a prescribed blood thinner should inform the clinician, but should not independently skip or double a dose unless given specific medical instructions. Gout and other inflammatory joint conditions can produce sudden severe pain, warmth, and swelling, often centered around the big toe, ankle, or knee. These conditions can also resemble infection. Fever, spreading redness, a wound near the joint, or feeling systemically unwell increases the need for urgent evaluation. Superficial vein inflammation. A clot and inflammation can also develop in a vein close to the skin. This is often called superficial vein thrombosis or superficial thrombophlebitis. The area may feel like a tender, firm, or cord-like line beneath the skin. There may be local redness, warmth, and swelling, sometimes along a visible varicose vein. Although this is different from DVT, the two conditions can occasionally occur together, or the clot can extend toward the deep veins. New superficial vein symptoms should therefore be discussed with a healthcare professional, especially when the affected area is extensive, close to the groin or behind the knee, or accompanied by whole leg swelling, breathlessness, or chest pain. Medication and body-wide causes. Several medications can contribute to leg swelling. Examples include some blood pressure medicines, anti-inflammatory medicines, corticosteroids, hormones, gabapentin, pregabalin, and certain diabetes or cancer treatments. Medication-related swelling is often present in both ankles, but it may look worse on one side because of old vein damage, arthritis, previous surgery, or differences in mobility. The timing matters. Did the swelling begin after a new medicine was introduced, or after a dose was increased? Is it present in both legs, even if one is worse? Does it improve overnight? These observations can help a prescriber or pharmacist review the situation. They are not a reason to stop a prescription independently. Suddenly stopping certain medicines can be dangerous, and the drug may not be the true cause. Heart, kidney, liver, and thyroid conditions may also cause swelling. They more commonly affect both legs and may appear with other signs such as breathlessness when lying down, unexpected weight gain, abdominal swelling, reduced urine output, or marked fatigue. But general rules have exceptions. A systemic condition may worsen swelling in a leg that already has damaged veins or lymphatic drainage. That is why the complete medical history matters. How clinicians investigate a newly swollen leg. The assessment usually begins with 3 questions. How quickly did the swelling appear? Is it truly limited to one leg? And are there symptoms suggesting DVT, pulmonary embolism, infection, injury, or impaired circulation? The clinician may ask about recent operations, hospital stays, cancer treatment, long journeys, falls, reduced mobility, previous clots, current medication, and family history. The leg may be examined for tenderness, warmth, skin changes, wounds, varicose veins, joint swelling, and the distribution of the edema. The pulse and circulation in the foot may also be checked. When DVT is suspected, guidelines recommend using a validated clinical probability assessment rather than relying on one symptom. Depending on the level of probability, testing may begin with a D-dimer blood test, a leg vein ultrasound, or both. A positive D-dimer does not diagnose DVT by itself, because many conditions can raise it. Ultrasound is used to look for evidence of a clot in the veins. D-dimer levels tend to become higher with age and with several illnesses. NICE advises clinicians to consider an age-adjusted threshold in people over 50, which can reduce unnecessary imaging while maintaining an evidence-based diagnostic pathway. This is a clinical calculation, not a result viewers should interpret without professional guidance. If the first ultrasound is negative but suspicion remains, repeat imaging may sometimes be needed. This is particularly important when symptoms persist and no convincing alternative explanation has been found. Testing for infection, injury, heart disease, kidney disease, or other causes depends on the examination and wider symptoms. There is no single blood test that explains every swollen leg. A practical action system. Here is a simple way to decide what level of help may be appropriate. First, check for emergency symptoms. Sudden breathlessness, chest pain, coughing blood, fainting or severe lightheadedness alongside leg swelling means emergency help now. Second, consider whether the swelling is new and unexplained. New one-sided swelling, especially when it appeared over hours or days, deserves prompt professional assessment even if the pain is mild. Third, look for infection features. A hot, tender, swollen, or spreading area of skin, particularly with fever, chills, or feeling unwell, requires urgent medical advice. Fourth, identify recent risk changes. Mention recent surgery, hospitalization, bed rest, long travel, cancer treatment, leg injury, a cast, reduced mobility, hormone treatment, or a previous clot. Fifth, record useful observations without delaying care. Note when the swelling began, whether it is increasing, where it starts, whether the whole leg is affected, and whether there is pain, warmth, color change, a wound, knee discomfort, or fever. A photograph taken at the start may help show whether redness or swelling is spreading. The photo should support medical assessment, not replace it. If the swelling is chronic, mild, and unchanged, arrange a routine discussion, particularly if there are skin changes, repeated infections, increasing heaviness, reduced walking ability, or a wound that is slow to heal. After meaningful value like this, consider sharing the video with someone who assumes every swollen ankle is simply part of getting older. What not to do while waiting for assessment. Do not use leftover anticoagulants or another person's medication. Do not stop a prescribed blood thinner, blood pressure medicine, or diuretic without instructions from the clinician responsible for it. Do not repeatedly squeeze or deeply massage a newly swollen, painful calf. Do not rely on whether the swelling leaves a dent. Both serious and non-serious conditions can produce pitting edema. Do not assume the absence of redness means there is no clot. Do not assume visible redness proves infection. Do not begin strong compression solely on internet advice when the swelling is new, painful, associated with poor circulation, or has not been medically assessed. And do not delay emergency help because the swollen leg itself does not look severe. A pulmonary embolism may occur without dramatic leg symptoms. The final takeaway. One-sided leg swelling after 60 is not a diagnosis. It is a sign with several possible explanations. Gradual swelling that worsens after standing may point toward chronic venous disease. Persistent swelling with heaviness and skin thickening may suggest impaired lymphatic drainage. Swelling linked to knee stiffness may involve a Baker's cyst. A hot, tender, spreading area may indicate cellulitis. But sudden, unexplained swelling must bring DVT into the discussion, particularly after surgery, hospitalization, reduced mobility, cancer treatment, or a previous clot. The safest approach is not to panic and not to dismiss it. Check for emergency breathing or chest symptoms first. Seek prompt assessment for a newly swollen leg. Bring an accurate medication list and explain when the change began. Understanding these distinctions can help protect mobility and independence, but understanding them is not the same as diagnosing yourself. For more evidence-first guidance on warning signs, medication safety, and maintaining independence after 60, subscribe to Health Insight.